So I'm delighted to introduce to you Dr. David Chan. David comes from Stanford today, and so we're switching to something a little bit different. David has both the PhD in economics and an MD. And you'll see that in the type of what he's talking about today. He tends to take things from a physician's perspective with a terrific economic lens. And so, for example, in some of his research, he's looked at emergency department physicians and finds if they're able to control their own schedule, you actually lead to higher throughput and productivity in the emergency room rather than having someone set their schedule for them. Other work he's done, he's looked at residency training, and he finds that residents actually learn the most when they become more senior in their positions. It's when they actually get the opportunity to make decisions that they learn from making those decisions, and that influences what happens there. But today he's actually going to talk about a part of Medicare that I'm not familiar with so much, and I'm looking forward to hearing about it. David.
Thank you very much. It's an honor to be here. So today I'm going to be talking about how we set prices for physician services. I'm just going to skip to the chase here and basically say the answer is not through what a neoclassical economist would say. It's not by market clearing. It's not by a free market. Instead, there are big players in this environment that set the price for physician services. So the first are public payers. In particular, there's Medicare and Medicaid, and the way they set prices is through committee and through statute. And this is what I'm going to be spending most of my time talking about today. And then, of course, private payers in this environment, and they are big payers as well, and the way they set prices is through negotiation and through bargaining with often big provider groups, and oftentimes they actually follow Medicare's lead. They follow the government's lead. So why do we care about how we set prices? There are at least two main reasons, other than just how much are we taking home as doctors to buy a house, and those are first, physicians respond to prices by their treatments. So there's research showing that if you raise the price of one chemotherapy drug versus another, the oncologists are going to choose that chemotherapy drug by a large degree. There's also research on how obstetricians make C-section decisions, and also there's some evidence that they respond to prices as well. And there's just, more recently, Clemens and Gottlieb have shown that physicians respond to prices overall, the overall level of prices in terms of providing more services when prices are higher. Second, there's also research that shows, not too surprisingly, that physicians consider their future income when they're choosing their careers. So if you look at medical students, and if you look at some variation in whether a career in dermatology is going to be more profitable than a career in primary care, there's been some research that has shown that that does influence kind of career choices. People are more likely to be a dermatologist if it's more profitable to be a dermatologist. So in short, we care about prices because prices determine how healthcare is delivered. It determines this both in the short run, when physicians are making choices in terms of what drugs to give, but also in the long run when we're asking how many primary care doctors do we have relative to dermatologists. So I'm going to focus on this talk on the role of government here, and I'm going to motivate it just primarily by saying government is a large player. Most of you in the room will already know that Medicare is a large player in the healthcare environment. Its spending alone accounts for 2.7% of the GDP, and $70 billion per year of this is spent towards physician services. Second, we know from research, again, that Medicare is a leader. Basically, it determines what the private insurance payers are going to do. So on the left panel, we have basically physician prices set by private insurance and as a function of Medicare prices, and we see that in terms of levels, prices are correlated between private insurance and Medicare. And on the right panel, we show that changes in prices are correlated with changes in prices in Medicare. So private changes in prices tend to increase when Medicare changes in prices tend to increase. So as an outline of the talk, I'm going to just kind of walk through the anatomy of government payments. So it's a relatively simple formula at first, but I'm going to look under the hood, and I'm going to kind of zoom in on a few of these things in the formula. So I'm going to spend some time talking about geographic adjustment, this thing that we call the conversion factor. Then I'm going to spend a little bit more time on what we call relative value units. Basically, these are going to determine the relative price between an office visit or a skin excision. And then I'm going to conclude by some larger issues and potential reforms. So this is the Medicare formula. So first of all, Medicare is going to make a payment, and so does private insurance, and it's going to make a payment for each service that a physician does in a fee-for-service world. And these services themselves have codes. So the CPT code, or current procedural terminology code, will identify the various services. And depending how you count them, there's 5,000 to 7,000 of these. So just straight off the bat, one of the themes I'm going to be it's going to run through this talk is that physicians have an important role in just even defining what the services are that they're providing. So it's at this kind of code level, and then what are the next steps? So given a CPT code, we have a payment that is a function of kind of 3 different types of work or inputs that go into this service. So first is the physician work. This is how much time and effort the physician spends on that service. That kind of takes up 50% of the payment. Then the next one, which is a non-trivial amount, and there's actually not very much research on this, but these are the practice expenses that a physician incurs. So there are nurses involved in the procedure, whether it requires a hospital bed, how many sponges or surgical equipment, and how you're using a CT scanner, for example. So that's practice expense. And finally, 5% of it goes to malpractice insurance. So of these 3, for each of these 3 categories, there's something called a geographic practice cost index, which adjusts by location. I'm going to talk a little bit about that. And then finally, you're going to have a conversion factor that transforms an RVU, or relative value unit, into dollars. So this is kind of hovered around $30 to $35 per RVU. So this looks like a simple formula, and what I'm going to be doing for the rest of the talk is I'm going to be looking under the hood, and what's not on this slide are important kind of features of pricing, such as bargaining, politics, and there's a lot of imprecision. So it looks like a technical formula, but actually underneath that, there are going to be a lot of kind of guesstimates, a lot of imprecision, a lot of lack of information that we need to actually set these prices. And the point is that this imprecision and this potential bias in politics, this essentially is, basically this shifts hundreds of millions of dollars between doctors and potentially could drive the decisions that doctors are making. So first, looking at geographic adjustment, I'm just going to read the definition that's on CMS's website on what a GPCI is. Each of these 3 RVUs are adjusted to account for geographic variations in the cost of practicing medicine in different areas of the country. So it sounds like a pretty non-controversial idea. And the idea is that it costs more to practice in certain places of the country, like California, than other places like Nebraska, for example. So I'm first just going to say that the way that we draw these boundaries has been pretty arbitrary, just in the same way that we draw, congressional voting districts, or kind of voting. Basically, how do you determine the geographic boundaries between areas that basically, in turn, drive how spending and resources are used? So first, in 1965, there were 210 different areas, and this was changed to 89 in 1997. Now, I was really interested to kind of look at Texas as a case. So you have 7 urban areas, or so-called urban areas, which are Austin, Brazoria, Beaumont, Dallas, Fort Worth, and Galveston. Not being a Texan myself, I had to go to Google, and I typed, "What's special about Brazoria?" I actually couldn't find anything special about Brazoria other than being at the Brazos River, which is the birthplace of Texas, apparently, but has a population of 3,000 in Brazoria. In contrast, you have San Antonio, which is the 3rd largest MSA in Texas and has a population of 1.5 million people, and that is actually lumped in with rural Texas. So presumably, what this payment kind of scheme is doing, it's actually you can imagine that San Antonio is being paid less than it should by having the same prices as rural Texas than Brazoria would. So you actually see Brazoria having a higher price than San Antonio, Texas. And kind of just more generally, if you look at the history of this, you have these cost of living indices, already calculated for every single location in the U.S. But as a political compromise, these are downweighted by 25%. So in other words, if it costs 10% more to live in one location versus another, this is mechanically kind of downweighted to be only 2.5%, different in terms of this GPCI. So this is another thing. If you just look at Medicare's GPCIs, comparing 2 points in time, one thing really sticks out. So in 2007, a lot of this fits my prior. So Santa Clara County, California, that's where Google and Apple are. And myself living in Santa Clara County, I can attest it's quite expensive to live there. So that has basically an 8% higher GPCI than the rest of the US. So the standard here is that the normal index should be 1, and it would be higher than 1 if it's more costly to live there. San Mateo, same thing, you have YouTube there, then Manhattan is number 3. What happened in 2008 was that Alaska shot up to 1.5. And what happened there? So there were 2 senators, Ted Stevens and Lisa Murkowski. In 2008 was around the time of the ACA, and they happened to get a good deal and say Alaska should be at 1.5. And that's way farther than Santa Clara, San Francisco, or Brazoria, for that matter. So that's geographic adjustment. The second thing I'm going to be talking about is the conversion factor. So I intentionally put a lot of math on this slide, not so that you can understand it, because it's actually it's almost impossible to understand. So a co-author of mine, Mike Dickstein, and I saw these formulas. Actually, we had to put it in a more kind of understandable form, but we still didn't understand it. We called the Congressional Budget Office, talked to some folks, and I think we probably understood it for 30 minutes and then forgot what it meant afterwards. And there are many things floating around here. There's a Medicare Economic Index. There's apparently TFP, which is total factor productivity, and GDP inside of there. And there's an update adjustment factor, and then there's a budget neutrality factor. So it looks very technical. It's very complicated. Nobody can really understand what it is. But the point is a bigger point, and that is that it depends on these economic indices that are actually quite coarse and fluctuating. If you actually plot the conversion factor over time, it jumps around a lot. And that implies hundreds of millions or billions of dollars in spending. But the bigger point is that none of these things have anything to do with an economic concept that we actually want to peg to physician prices. It has nothing to do with marginal cost, it has nothing to do with average cost, or any fundamental economic object that's related to physician payment. So what this is doing is it's adding some technical details that's actually causing a lot of bouncing around that is not pegged to what we actually want to do in terms of physician payment. And then more so, this is not immune to politics. So one of the components in this called the sustainable growth rate, or the SGR, has implied, so in the recession of 2002, because it's pegged to GDP, it implied that we needed to cut physician payments by 5%. And Congress was not able to do that. They didn't have the spine to do that because there would be political implications for that. So instead, what they did was they said that we're going to pay for this later. I don't know if this sounds familiar. So what happened then over the next 15 years was they racked up a debt of about 20%. So if they were to honor their debt, they would have lowered physician payments by 20%. Of course, they were never going to do that. So in 2015, they abolished the SGR, and we switched to another setting. So even if you look at this technical formula, the bottom line is we never followed the technical formula when it was inconvenient to do so. All right, so now I'm going to spend a little bit more time on relative value units. Now, relative value units, I think, are probably one of the most important things, when we're asking about how does this affect how healthcare is delivered because it essentially determines the relative price of various procedures. So it's going to determine whether chemotherapy is reimbursed more than an office visit. And so this will affect physician decisions, from my first kind of motivation slides. So these are just some of the examples of RVUs across services. And so we have a level 3 office visit. It's kind of a moderate intensity office visit, which has an RVU of about 1. And you have a simple cataract surgery, which has an RVU of about 8.5. So that means that regardless of where the conversion factor is, regardless of what the GPCI is, we're always going to be paying a simple cataract surgery about 9 times more than an office visit. And then you have some of the most expensive surgeries. The most expensive one is actually a repair of a diaphragmatic hernia, which I'm not sure why it's more expensive than a heart-lung transplant, but that's about $3,700. And then the least expensive one is a skin prick to test whether somebody has an allergy to something. That's about 34 cents. So the reason why this is important, as I mentioned, it determines what physicians are going to do, but it also determines how money is going to be divided amongst specialties. If you're going to increase the price of office visits, then primary care doctors are going to get relatively more, relative to if you're going to increase the price of a skin excision or a cataract surgery, then the dermatologists and the ophthalmologists are going to get a little bit more. So what goes into an RVU? So under the hood of an RVU, there are many things that need to be considered, and you just think about how you're going to measure these things. Some of these are essentially just asking doctors how they feel about something. So one is the time to perform a procedure. Does it take 40 minutes for an office visit as opposed to 5 minutes for a cataract surgery? So obviously that's not going to capture everything that we want to consider about paying physicians. The second is like the intensity of the procedure, and this is where it's important, but it's hard to measure. So you've got mental effort, technical skill, just reading off of the official kind of description of RVUs, physical effort, and psychological stress. So some of these things you have no idea. The only way you would get a measure of psychological stress is to actually ask doctors, how stressed do you feel when you're doing this procedure? I'm going to get to the difficulties of that exercise in a little bit. So it's you may laugh, but it seems a little bit weird to ask physicians how stressed you are, knowing that the physicians know that will determine how much they're going to be paid. But at the same time, how would you assess this information? This is if you say that this information is important, which it arguably is, you would need to ask physicians for that information. So that's going to be a theme throughout this talk. So the fundamental difficulty, suppose you were able to elicit this information perfectly. There's still another fundamental difficulty, is that how would you compare psychotherapy with heart-lung transplant? Because there is no doctor that does both psychotherapy and heart-lung transplant, or at least official psychotherapy. So in order to kind of actually put both of those on a relative value scale, you would need the doctor to say, I'm 100 times more stressed when I do heart-lung transplant than when I do psychotherapy. Instead, what you have is like a group of doctors, psychiatrists that do psychotherapy, and another group of doctors, heart and lung transplant surgeons that do heart and lung transplant. So you're going to get different kind of measures from different groups of doctors. And so how would you do this? And the answer from an economist is to use econometrics. So it's a little bit magic. So at least since 1992, what they found is if they ask psychiatrists whether psychotherapy is harder than an office visit or prescribing antidepressants, then they would get pretty good agreement among psychiatrists which one is harder if you ask them about procedures that they do. But then the difficulty was, again, how do you compare the relative value between psychotherapists and heart and lung transplant surgeons? So they would have to find these procedures that were done by both psychiatrists and heart, lung, and transplant surgeons, and these procedures would essentially be the backbone that we would use to then say, well, a psychotherapist says an office visit is an RVU of 3, and a heart and lung transplant surgeon says an office visit is an RVU of 5, so therefore we're going to deflate the heart and lung transplants values for all of their services, using kind of these common services. So this is just putting it in a regression form where you have like some survey measure, and then these survey measures are given for each service and by specialty, a physician specialty. So you're going to use a regression then to say what should the RVU be for that, and what's this adjustment factor alpha that I'm going to use to kind of downweight the heart and lung transplant surgeons. So that's all well and good, but the economists here in the room will know that all of this, again, depends on this kind of backbone, which can be a very small backbone of services that are provided by different specialties. And if you look at the entire schedule of CPT codes, these services are a small minority. They're less than 10% of the CPT codes in the entire kind of schedule. And so this can be quite fragile. Assumption that an office visit performed by a psychotherapist is equally difficult as an office visit by a heart and lung transplant surgeon. So there are assumptions that we need under this hood. So this kind of veneer of scientific, of a scientific approach depends on kind of key assumptions that are not necessarily true. So aside from that, what needed to happen from this initial, so all of this kind of regression stuff, that was in 1992 when they implemented RVUs. But the bigger problem is that we need to update RVUs, right? Medicine changes. The patients that once got laparoscopic surgery versus the patients that now get laparoscopic surgery are different. The kind of technology might be easier to use now than when it first came out. And documentation, there are a number of different things in the healthcare system that will make a CPT maybe easier to do in one period and maybe like harder in the next period. And we need to update this, not to mention that there are many new procedures now that weren't around in 1992. So this kind of leads us to this committee. It's the American Medical Association Relative Value Scale Update Committee, or the RUC. And this is basically a committee of physicians where they have special interest groups on this committee. So there will be an internist on the committee, there will be a heart and lung transplant surgeon on the committee, there will be psychiatrists on the committee. And the job of this committee, since it's from the AMA, it's actually not part of government, is only to recommend decisions to the government. But what happens is this committee is quite influential in that the government listens to its recommendations 90% of the time or more. So what I'm going to be talking about in the next few slides is looking at this committee's performance and why would we have such a committee. To some extent, it's necessary because we need information from doctors. On the other hand, there are some concerns with this committee. So this is just a kind of overview from the AMA's website on the various steps that could lead to a price. So there are different kinds of, So there are different boxes up there that kind of represent how a code could come to the committee. So this would basically say that we have some codes that need to be updated, and there are various numbers of pathways that we could kind of get to that point. Then when we get to the bottom there, or basically the middle of it, that's when this RUC committee will listen to input from the Specialty Society RVS committee. So we should think of those committees as special interest groups. These specialty societies are going to lobby the RUC for a certain price on procedures that they do. And remember, the RUC again has members of these specialty societies on its board, and then they will decide whether to agree with the price change or not, and then propose it to Medicare, which then will put it in the Medicare payment schedule. So this is how the committee looked like in 2015. There are 6 members that are not from specialty societies, and these actually, some of these are non-voting members, and there are about 25 members from specialty societies. So most of these are permanent members, although the committee has grown in size over time, but these are now the names of the specialties without the asterisks are permanent members of the committees. And you have some seats that are held by rotating members, such as hematology is a seat for internal medicine subspecialty, or you have colon and rectal surgery, which is a seat for a surgical subspecialty. So this is basically the composition of the committee right now. And if you look at this composition, you'll see what many critics have kind of raised is that internal medicine or family practice, the primary care seats are quite underrepresented. If you kind of look at the population of doctors in internal medicine versus family practice, they are a much bigger share of the population of doctors than they are on this committee here. So we're going to talk a little bit about that. So the criticisms, one of the criticisms is that if you have physicians setting their own prices, isn't this a bit like the fox guarding the hen house? So you have this potential concern of strategic agenda setting. So whether the committee even decides to update a price or not is its own decision. If the committee makes no comment about a price, then the price won't be updated unless if CMS specifically asks the committee, but sometimes the committee can voluntarily say, we're gonna recommend that you change this price. And then there is a concern, it's amongst people that don't understand this process that the committee would just kind of increase prices without bound because they're never gonna decrease price, but of course then the committee is only setting relative prices, it's not setting the overall budget of care, but this is, again, a general concern about having doctors set their own prices. The second one is that specialists are overrepresented, and there is a general kind of policy concern that we don't have enough primary care doctors because the work of being a primary care doctor is hard relative to how much you're getting paid. And is this committee a reason for that? So that's another thing that we looked at in our study that I'm going to be talking about. And then second is this intuitive sense that how can this committee set accurate prices when what it's doing is surveying just a few physicians. You can set a price by just surveying 20 physicians. And you can imagine just getting the wrong physician on that day and the price changing by 5%, that would be tens of millions of dollars. And so how we go about this process is not all biased. There's just this imprecision that we get when we rely on basically rely on an outside entity to survey physicians and survey quite few of them in many cases. This could lead to arbitrary and imprecise prices. So the first kind of study I'm going to go into is by my colleague Mike Dickstein. This is an economics study that we are basically asking the question of, we're looking at this RUC as an advisory committee, and we're wondering whether it's a source of bias, kind of answering this question, is the RUC composition a reason why we don't pay primary care physicians enough? And we take a step back and say that the RUC is actually not unique when we look at the functioning of American government or governments around the world. The RUC is it's an advisory committee that we have in many different settings. So if you look at kind of congressional documents, ever since the 1970s, they've been required to disclose all the committees that advise them in making rules, and there's more than 900 committees on issues as varied as what do we do about global warming, or what are we going to do about airline safety? And if you look at the members on these committees, for the global warming committee, you will have people from industry, from oil industry, and from the airline safety committee, you will have people from Boeing. And so the concern ever since the 1970s is that is this a mechanism for regulatory capture? Is this a source of bias? This is where most of the policy discussion has been on, whether we're just kind of shading the outcome in favor of people on the committee. So it's been mostly on bias, but we're also going to look at this important role of information, because after all, why would you even have these committees in the first place? Well, the reason is that we need important information about how to produce an airline, about what are some of the costs and benefits of various means of producing energy, and most importantly for this case is what actually goes into producing physician services. So that's why we need to have physicians on these committees. So the empirical approach that we took in this is that the first step that we needed to do is to measure affiliation between specialties in order to get a better sense of how related is a psychiatrist with an internal medicine doctor on this committee. We need some quantitative measure to measure relationships between specialty societies. Then we used unique data from the RUC, and looked at the proposals to the RUCs ever since 1992, its inception in 1992, and looked at whether affiliation between proposing specialties and the RUC led to higher prices for specialties that were more affiliated to the RUC. And importantly, we were very interested in how this influenced not just the prices that they got, but the informational content of these prices. So we also looked at how much work did they put into these proposals, how many doctors did they survey when they are kind of coming up with these proposals, as well as how do these prices track with other prices in private insurance as a measure of the quality of these prices. So this is getting at both at bias as well as the importance of information and the potential risk of imprecision when you're setting these prices. This is just to show that we use a number of mathematical procedures to map the affiliation between two specialties by looking at the procedures that they do. So if two specialties do more procedures in common, then we're going to say that they're more affiliated. Essentially, there are a number of ways to come up with distance metrics that we're going to borrow from the computer science and mathematics literature. And when we do this, regardless, we do a number of different metrics, and we find some pretty robust relationships between specialty societies. So the first thing that we find is that internal medicine and general surgery and family practice are actually quite affiliated with many specialties. And if you think about it, this makes sense because they're doing a broad range of services, and therefore they're going to share these services in common with other specialties. On the other hand, very interestingly, we find that emergency medicine has a very low affiliation with most specialties. And why is that? Because you would think that emergency medicine also does all of the same procedures. They actually, in fact, see labor and delivery in the emergency room. They see a number of, they see the internal medicine complaints as well as the surgical complaints. But the key thing is that the definition of the CPT code for an emergency medicine visit is called emergency medicine visit, as opposed to outpatient visit or inpatient visit. So this gives emergency medicine its own CPT code, which is higher than an outpatient visit, but it essentially puts it on an island. It's actually not related to any of the other specialties because no other specialty does an emergency visit. We also find other things, such as even though internal medicine is quite affiliated with a lot of specialties, some branches of internal medicine, like allergy and immunology, are not affiliated at all because they're doing very different procedures. So then finally, we're going to take these affiliation measures and we're forming a measure between kind of a proposal to the committee and the committee itself, using potential variation on who's on the committee at that time, this R, and then who are the specialties that are proposing to the committee. I'm going to skip over this. And the first thing that we find is that the higher the affiliation, the higher the price. So we do find evidence of bias here. And the bias can be viewed as non-trivial. So if you increase the affiliation by 1 standard deviation, you're increasing the price by 10%. That's a non-trivial amount that I'm going to show you on the next slide. Basically, this means that $1.3 billion of Medicare spending annually would be redistributed if there was no bias. And if you include private insurance spending, that would be about $9 billion of spending would be redistributed if you didn't have bias. But the kind of plot twist here is that actually it does not explain why internal medicine or family practice, people think they're underpaid, actually, but we find that they have higher affiliation. So they would actually be losers if we got rid of affiliation. So they actually benefit from affiliation by being more affiliated with a broad range of specialties, and they gain quite a bit from the fact that there's connections between specialties. Instead, you would have the narrow specialties like so you would have basically the narrow specialties like ophthalmology or emergency medicine benefiting if you got rid of affiliation. And if you look at the proposal to increase the number of seats on the RUC with primary care affiliation, so if you increase the number of internal medicine and family practice seats by 4 times, that would increase their revenue by a very small amount because they're already quite affiliated with all of the other specialties. So if you just kind of replace an affiliated kind of specialty with internal medicine itself, it actually doesn't result in very much of a difference in revenue to internal medicine. I'm going to talk about the potential reasons why internal medicine might be underpaid in a few slides. Then we look at the role of information. So we find evidence that's consistent with economic theories. So there's 2 different types of information. One is evidence, you can call evidence or hard information. And basically the theory would say that the more affiliated you are with somebody that you're trying to persuade, the less hard evidence you're going to bring into play. So if you kind of think about you trying to persuade your mom that I've written the best paper ever, we're very affiliated. She has the same interests as me, so I don't actually have to give her any proof that I've written the best paper ever. On the other hand, if I'm trying to persuade a journal editor that I've written the best paper ever, I would have to give proof. On the other hand, so in that sense, hard information or evidence is going to decrease in the prices if you increase affiliation. But on the other hand, there's communication, what we call soft information. And so the idea is the more affiliated you are, sometimes the better communication you can have. Communication can break down if you have no shared interests. And so we look at this empirically by looking at the evidence that people are bringing to in their proposals, how many people are surveyed in their proposals, and we find evidence to support that hard information goes up. So they survey more people when they're less affiliated with the RUC. But on the other hand, soft information might go down. The prices that are set when they are more affiliated with the RUC tends to be closer to what private insurance is doing. So in the sense that there is some underlying truth here, there tends to be more kind of targeting to this truth when there is more affiliation. So basically, this is highlighting an important kind of trade-off here. People have focused on bias in the RUC, but the entire point of asking physicians about the things that they do is to gather information, and if we don't have the information, then we could end up with prices that are just as arbitrary and potentially off the mark than if we don't involve physicians here. The second study is now looking at more a statistical accounting framework of surgical procedures, because in surgical procedures we can actually observe how much time surgeons actually do when they're doing each procedure, each CPT code. So we have a measure of this in a national database called NISQIP, and we're going to compare these with what surgeons are telling the RUC in terms of how long these procedures take. So we're then going to ask, is there a systematic bias when surgeons are reporting their procedure time to the RUC versus what we actually observe in the data? And how much imprecision is there? So even though there might not be any systematic bias on average, to what extent are they off the mark when you compare the national database with these surveys that they submit to the RUC? And then we're going to ask, does the RUC help to reduce this imprecision? So when they kind of update a procedure time that we see in the data, does the update get closer to the mark than it was before? And what are the revenue implications of any imprecision on surgical revenue? So the first thing that we find is that there's relatively little bias between what surgeons are telling the RUC in terms of how long they're taking and how much we actually see what we call benchmark time in this national database. So if you draw a 45-degree line or a slope of 1, there is not much systematic bias. It depends on how you look at this. I think, and if you look at the data a little bit differently, you get some bias. If you, for example, take into account the fact that some procedures are performed jointly in the National Surgical Database, so you kind of need to downweight the time. But the bias is never more than 9%, depending on how you look at it. On the other hand, there's much more imprecision. The mean difference between the RUC time and the surgical time is about 20%. That means that they're off on average by about 20%, whether it's up or down, they're off. And so that results in that. Another way of saying that, there's a lot of imprecision. A lot of what surgeons should be paid based on the truth is not being captured using these surveys, which again could be asked amongst just 20 surgeons. So given that, the size of these surveys, it shouldn't be that surprising. Then we ask whether the update process improves some of this imprecision. So the black arrows show some procedures that used to be more away from the 45-degree line and kind of go closer to the 45-degree line. And the gray arrows are showing improvement, and the black arrows are showing the opposite, where you used to be closer to the 45-degree line, and the ruck actually made you farther away. So we find that there is, on average, more improvement than kind of moving away to the ruck. So the ruck is kind of getting closer to the truth, but again, there's a lot of imprecision when you rely on these surveys as opposed to looking at the national data. And that these have large revenue implications. So if you look at the main surgical specialties that provide these procedures in our data, orthopedic surgery to cardiothoracic surgery, you could have hundreds of millions of dollars changing hands just if you kind of switched from this survey approach to a more systematic approach that used data to set these prices. And that this is not just hundreds of millions of dollars, it's also a large percentage of these revenues that the specialty societies are getting. So orthopedic surgery could experience, basically what I think the losers here are the ones who are paid too much are orthopedic surgery and urology, who have close to maybe 2% overpayment, versus cardiothoracic surgery actually is underpaid by quite a bit. More than 6% of its annual revenues is lower under the survey system than under a system that uses actual data. So as a take-home from the research is that we've been focused to a large extent in the policy discussions about the potential of bias, about the fox guarding the hen house in setting relative prices. But the role of information is very important here. If we decide that we want to reimburse physicians by how much time they're spending or how costly it is and how much effort it is, we really need to ask physicians. And if we don't get a good measure of this, then the role of imprecision is potentially much larger in setting prices wrong. And we've only kind of focused on the time dimension. How long are physicians spending on a procedure? You could imagine that some of these other ones, such as physical effort or psychological effort, are much more difficult to measure. So this is not saying that we can solve all of our problems moving from surveys to a national data set, but we can improve quite a bit, at least if we kind of substitute some of these survey items with the national data set. And the key kind of trade-off here I want to emphasize is that there sometimes is a bias between, it is a trade-off between bias and information. If we want to get rid of all bias, it's easy just to not ask physicians at all, but then we would have extremely and unacceptably imprecise measures of their work. So finally, I want to talk about some of the larger challenges that we have here and that we haven't addressed in research yet. So again, it's the fundamental issue of comparing different services, psychotherapy versus heart and lung transplant. And what should be the conceptual benchmark for prices? So this entire talk, I've been talking about how we're trying to measure work or marginal cost of performing a procedure. Should this be marginal cost, or should it be average cost, or marginal benefit? Typically, in economics, when we're talking about how much we want to pay as a consumer for something, is not how costly it is, but how much benefit it's getting me. I'm going to buy an iPhone not because it costs a lot to make it, but because it's useful to me. And so that is, a whole, that's basically a whole nother discussion of how should we set prices, and it's like much farther away than what we're currently doing, and we should maybe be having those discussions. How should we pay for physician services? Is it by cost? How much work is it? Or how much benefits delivering to consumers? Then I also want to emphasize, it's kind of come up a few times in the talk, is that political issues are going to be intrinsic because you have people that benefit from a procedure that have necessary information that you need to survey or need to extract from them when you're pricing something. And there are some general political issues that exist outside of medicine that are going to be at work here. So Gary Becker in 1984 made this observation that in urban countries, the rural people really are able to extract a lot of rents. And in rural countries, the folks who live in the cities extract a lot of rent. And basically the idea of this is that when you have a small share of the pie, you're able to extract more out of that pie because nobody really cares about how much extra we're going to give you. So this is another example of Alaska, right? Like Alaska is a small percent of our overall spending, so they can extract 50% more and nobody will care that much about it. And so this will then kind of extend to our discussion about primary care. Primary care is a large number of physicians. What they do is a very common thing called the office visit. And if you were just to increase the office visit by 5%, that would have huge revenue implications for everyone else, as opposed to increasing the price of a cataract surgery or the price of a skin biopsy by 50%. So there are some intrinsic political issues that we somehow need to address here when we're trying to figure out how to equitably pay or efficiently pay across different services. And then finally, there are technological issues. So we are pricing things kind of at a snapshot in time. We're asking how difficult it is to perform a given service, but that changes over time. And for some types of services, there is learning, such as much easier to do laparoscopic surgery now than it was 10 years ago. It's not much easier to do an office visit now than it was 10 years ago. So there is kind of inherent challenges when we're trying to figure out how should we price office visits if there's much more learning outside of office visits. It's going to put primary care at a disadvantage there as well. All right. I'm just going to briefly mention that there are some important reforms that have happened since 2015 that we're shifting very much to alternative payment systems and paying for performance. So if physicians kind of do more flu shots, they're going to get a bonus there. So that's maybe switching a little bit more to marginal benefit as opposed to marginal cost. But this backbone of measuring the work of a physician is still very much alive and kicking. So basically what we're doing, if there's a performance bonus of B, we're just multiplying that B times whatever RVUs they're doing. So a cardiothoracic surgeon for that performs a heart and lung transplant is with a 10% bonus is going to get much more than a primary care physician who does office visits with a 10% bonus. All right, so in conclusion, I want to say that for you to take away from this talk is that there is a countless number of regulatory decisions when we're trying to decide how to pay for physician services. And in each one of these regulatory decisions, you can think of a large scope for bias and imprecision. There's a very important role for information here. There's no other way to price physician services. Regardless of whether we look at marginal cost or marginal benefit, we need to gather information about that. And oftentimes, the very people that are being regulated also have that information. So there's no way, I don't think, to get away from that, to actually ask physicians how much they should be paid. There's potentially some scope for having data play a larger role, such as the NISQIP that we just showed. We can measure how long physicians actually take for certain procedures, but there will always be a role of regulated how much they should be paid. And third, this is not a unique US challenge. In contrast to John's talk, this actually exists in all countries that we surveyed. We had a research assistant look at all developed countries, all OECD countries, and every single country had a payment system that was based on committee. So setting prices in this way is not a unique US challenge, and we're gonna have to have some version of this regardless of the system that we have. And then finally, that regardless of how we change from paying a little bit more for performance, this process will remain important because it determines how physicians deliver care. And it's also very dynamic because the nature of healthcare is changing. We have new procedures. The difficulty of performing certain procedures will change over time. And given that we have rules and given that there's politics and bargaining, to some extent it will always be nonsensical. So the challenge is to kind of reduce some of this nonsensicality, but it will occupy researchers and policymakers for years to come. Thank you.
That was terrific, David. I'd say, gosh, maybe 20 years ago, I was working in University of Alabama, Birmingham, and I became aware of these differences in the regional regional differences in reimbursement, and there was a vascular surgeon there who had so many patients who needed sort of revascularization of their lower limbs because of diabetes, and they had so many that they ended up with many more amputations than you would find in other parts of the country. So how about adding into adjusting the reimbursement rates this sort of, I don't want to compensate physicians who live in San Francisco more, because clearly you all like to live there, and the reason—
You said you don't want to compensate more, or you do want to?
I don't, because I understand there's a higher cost of living, and maybe you want to do some of that, but there's so much incentive for physicians to work there, and not enough incentives to work in Birmingham, in the South, in lots of parts of rural Texas. What do you think of that?
Right, that's a very good question. I think this is part of the argument that Senator Stevens and Murkowski were making, that maybe this shouldn't just be about the cost of living. Maybe it should be about whether we have enough physicians to do these services. And even if physicians are taking a pay cut, a relative pay cut by working in San Francisco, still there's a lot of physicians in San Francisco and not enough people taking Medicare patients in Alaska. So it's a good kind of policy point, but we need to kind of make that explicit. And so with this geographic price adjustment factor, basically what they're doing is saying that this is just cost of living, and they're now kind of baking into it other ways of accounting for physician shortages. So I think maybe one policy answer would be to actually make that explicit, to have regulations and laws that specifically act on whether there are enough kind of physicians and whether they're taking Medicare patients, and sort of decouple that, as opposed to have this kind of kludge of cost of living, a million other things in that formula, and then bake into that somehow, are there enough physicians to perform that service?
Good talk. Chris Skazak, Houston Business Coalition on health. So what I heard, at least based on RVU and RUC, that primary care physicians are not in that bad a shape overall relative to other specialties. Maybe I misinterpreted that. My question would be, in the States relative to, say, Europe, the role of the primary physician may be a bit different. I think what I'm trying to get at is maybe the RVU for the primary physicians should be increased if their role was changed, and perhaps most importantly, being an excellent navigator for the patient, which is not easy to do. I'll give you an example. I was in New York City this week at a global conference on mental health, and some may have heard of the collaborative care model of delivery, and believing that because of access issues, as an example, the primary care physician is best suited to help manage a lot of the mental health issues that we have in this country. So I'd appreciate your comment on that.
Absolutely. So I want to be very clear. I'm not saying that primary care physicians are not being disadvantaged here. So I think that there are systematic reasons for why primary care physicians are paid less than they should be. But first, when we look at the RUC, a lot of policy discussion was that maybe we could fix the primary care physician disadvantage by increasing the number of seats that they have on the RUC. And that is something that we show is not true. And then a related kind of policy discussion is that maybe the reason that primary care physicians are not paid as much as they should be is that we don't have enough, we have too many specialists who only care about their procedures, but those specialists actually share a lot of procedures with primary care physicians. I think the reason why primary care physicians are underpaid is actually very fundamental in how we've just designed the system to start with. So here in the US, they're paid fee for service, and the way that we've defined the services are because of what I just talked about. If you have like a service that is very commonly produced, there are political reasons why it would be very costly to kind of increase that by a little bit, as opposed to increasing how much we're reimbursing for a skin biopsy or a very kind of trivial but very uncommon procedure. And so the entire way that we're reimbursing primary care physicians by fee-for-service on a schedule of services that are defined in a way that has very common services like office visits versus uncommon services performed mostly not by non-primary care physicians, I think is the reason why they're being disadvantaged. And even more so, there are many things that the primary care physicians do that are not even on the schedule, right? Like there's no CPT code for navigating the system, and there's no CPT code for email, like an important kind of phone call with your patient. So as a result, you have incentives for doctors to not want to be available, but instead come to the office. Like if you have a question, even though I could answer it in 10 seconds, you need to come for an office visit. Or don't have email service, please come for an office visit. And that basically disadvantages the PCP because they have to spend much more time doing that, as well as the patient, and that leads to a lot of inefficiency. And if you look at countries in Europe, maybe we need to even kind of step away from a pure fee-for-service, kind of paying physician for every little widget that they produce, and there needs to be some kind of value of navigating the system, or even moving towards salary, where I think empirically, if you looked at countries or systems that had more salary-based mechanisms versus fee-for-service, then I think you would see that disparity between cardiothoracic surgeons and PCPs go down much more.
In taking a look at the composition of the RUC, I didn't see, and maybe I just couldn't read the list fast enough, any input from what I'd consider to be objective side of things, which would be maybe somebody from the technology side who could speak specifically to cost reductions, or to see specifically to how times have improved over the course of many years, or anybody from the consumer side, consumer groups, which could talk to the benefit or the relative benefit of many of these procedures. Has there been any effort to include any of those groups, or is it pretty much a closed shop?
Yeah, well, it's a good question. So I think part of the reason is that the RUC is housed by the American Medical Association. And maybe this also speaks to the relative kind of role that doctors have to play in the US versus in other countries. So while I said that, if you look at all of the OECD countries, they all involve some type of committee setting prices, but many of them involve people from hospitals or people from technology or people representing patients. So I would say the US is much more kind of doctor heavy when you're setting these prices than kind of other places. Not to say that doctors shouldn't play a big role, they should play a big role, but the process could be improved if you kind of had a broader committee. And maybe part of that would be maybe the committee shouldn't be housed within the AMA.
I just want to ask one more question. So maybe I'm getting history a little bit too simple, but when we set DRGs, we just had this smart Harvard professor, Bill Shao, who took all the data and came up with the DRG reimbursement for hospitals. Why not just take this whole system away? We've got much more just take it away from physicians. Hire someone who doesn't have a pony in the game, and let them have all the data that they want, and let them set the reimbursement rates.
So it's tempting. I think for DRGs, what we were able to do is we actually did an accounting process that saw dollars spent for a given patient. So there was some kind of benchmark. If we're trying to reimburse hospitals for how much they spend in terms of supplies and physician wages, so there again, I think what physicians are paid will kind of creep into that. But at least we have some measure of how much hospitals are spending for a given patient. Here, like what we're talking about, and I think there's some, if we're in this kind of framework where we are wanting to price according to cost, what physicians are doing can't be as easily observed as what hospitals are spending, because physicians aren't a business just only kind of transacting with, I'm gonna buy some sponges and I'm gonna costlessly produce this service with these sponges. They're actually kind of using their own time. So the big component of this is their own work. And how do you value that work is kind of the key question here. But I think underlying all of this is, should we have a system that prices according to work or cost versus a system that prices according to benefit? If they're pricing according to benefit, then we don't need to ask physicians as much about how difficult it is to do. They probably still have a voice in terms of what does the evidence kind of look like in terms of a potential benefit, but that would change the equation substantially.
Hi, I'm a retired lawyer. One of the things that happens in the legal profession is that our income is ultimately determined by judges on an individual basis, not in every case or even in a majority of cases. But there are many cases where judges determine the lawyer's fees on an initial basis, in bankruptcy and a lot of labor kinds of things, class action cases. And so there's a tossing back and forth between what's going on in the private sector and what's going on among what judges do, and they fuel each other. It does seem like to me that an analogous situation in the medical profession would be people more like hospital administrators determining what physician should be paid.
Right.
Because here the judges are in fact lawyers, but they're not functioning in that capacity when they're making the decision. So
Yep.
Just a little bit of information to toss in the mix there.
Yeah, I think that's a really good point. I think that kind of reflects a little bit on the previous comment over there, like why don't we include other people at the table, technology folks, or actually just people that run hospitals or people that run HMOs. And that was a proposal. So there was a former RUC member who became very dissatisfied with the RUC, who said, I proposed that we should include HMOs to give us some input on how much we should price these procedures, and he said he was kind of laughed out of the room. So maybe, again, it is just it's a function of how we design the committee structure, and in turn, how does, who houses the committee structure? Should the federal government take more of an active role here than rather just a passive recipient of whatever the AMA proposes? Great.
Thanks a lot, David. So we're going to take a quick break now. We'll meet back at 11 o'clock for the next speaker. And someone did leave their keys in the women's restroom, and they're being held at the reception office of the Baker Institute.